next speaker, that is Dr. Rohan Savant. Dr. Savant has done his extensive training in India as well as appeared for a lot of these examinations. In fact, he has recently cleared the FRCOPHTH as well, and he's currently working in the NHS in the UK, and we're very happy that he's been able to join us for this instruction course. He has a vast experience in all these examinations, but we are specifically, he's going to focus on the FRCOPHTH, and this is of special relevance for any of you who wish to emigrate, especially to the UK. Rohan, please, if you can.
Good morning, everybody. At the outset, I'd like to thank Devendra and Dr. Rashmin sir. Devendra mainly because he conducts this course and he is so much interested in giving back to the examinations or to people to share his experience, and I feel privileged that I can share my bit. And Rashmin sir especially because he is mentored through a lot of these examinations in the way and in the process to approach. So my talk today is my experience. So that's what I ended up doing. So a note about the Royal College of Ophthalmologists. As mentioned by Devendra in his slides, it was started in April 1988 as the voice of the profession in the UK. How does it help? It is considered as an exit level examination. It is a necessary qualification to be a consultant in the United Kingdom. Now recently it also provides PLAP exemption, which was not applicable when I gave the exam. That's why I ended up giving the Glasgow and the Edinburgh and the Royal College as well. And the latest update is this exam can now be exclusively given in India. You don't need to travel to UK to give any part of it. The exam format, as is with any general exam, 3 parts. Part 1, refraction, and part 2, which is decoupled now into written and oral. So where can you sit the exam? Part 1 and part 2 written are MCQ exams, which are now delivered online via remote proctoring, which means that you can sit in any country and there's no need to travel. The part 2 oral and the refraction certificate now take place every year in India, Trinidad and Tobago, Egypt, Singapore and Malaysia. In fact, they are starting their first part 2 oral exam later this year in Chennai, I believe, in November. A note about the part 1 exam. You don't need previous experience in ophthalmology to sit for this exam, and this exam is based on the curriculum outcomes of the first 2 years of the ophthalmic specialty training, which is a run through 7-year training in the UK. So you are expected to know the skills that are necessary to be a second-year resident in the UK. The exam is done 3 times a year. This might change because online proctor exams would be offered to many more candidates, and the maximum allowed is 6 attempts. It's a 2-hour multiple choice paper examination, 2 exams of 90 questions each, consisting of 1 best answer. So I'm just trying to, yeah. So you can give it at your home or your workplace. This exam is delivered over the internet to a computer, your own computer, at a pre-agreed date and time, and there is a 1-hour break in between 2 papers. This is just an example of the kind of difficulty expected. Let's not go into details of that. Preparation, as you see, some of these pictures are quite similar to what Devendra shared in his files as well. So for basic sciences, for all 3 Royal Colleges, I can safely say that the preparation is quite common. There isn't, except the format of the examination, there isn't anything different that you need to prepare separately. Optics, again, Elkington, because again, Elkington was a British person. So, refraction certificate, you don't need to pass part 1 to give refraction certificate. You can give refraction certificate independently of whether you pass part 1 or not. So a lot of people gain a lot of clinical experience in refractions and give the refraction certificate first before attempting the part 1 theory. Again, you don't need any previous experience in ophthalmology. 3 to 4 sittings per year, max 6 attempts, and there was a paper version of marking when I gave the exams. Nowadays, it's been replaced by an iPad, so the answers are marked electronically, and there are centers in UK and Egypt. It's an OSCE type exam with 10 stations and 5 rooms. From November 2022, the exam is going to be conducted in hybrid format, which means that post-COVID, they are now starting to get patients to see face-to-face by the candidates. So it will be a good combination of simulators and face-to-face patients. So the exam is conducted in 5 rooms with 2 patients each. That makes it 10 stations. So 2 rooms will still have the simulator, but 3 rooms will have patients face-to-face. And the simulator retinoscope is the hind retinoscope with hidden trial lenses. This is the standardized OSCE format. So you can see that a lot of emphasis is based on retinoscopy. Part 2 fellowship. It is open to candidates after passing the Part 1 and a refraction certificate. It has a written and oral component, which again is considered as a synoptic exit level examination. So it uses different techniques, which are beautifully spread over a period of 2 sessions. And they use complementary assessment methods to see how well you do. So you're expected to demonstrate a depth of knowledge and understanding expected of an independent consultant. So it's not only a test of your knowledge, it's also a test of your demeanor, how you approach a question, how your facial expression is, and how nervous you feel on your face or you show if you're a bit out of water. So all that is actually watched. In terms of the trainees expected to pass the written and oral examination before they complete their training, which is 7 years. This has been decoupled recently, so you can give theory and oral of the FRCOPHTH separately, maximum 4 attempts each. With the written component, it's held twice a year. Again, it's a proctored exam. 2 MCQ papers, 90 MCQs each. You have to answer a single best response from 4 options, 2 hours each, 1 hour break, similar to the Part 1 proctored system. Again, it's curriculum based. This is a blueprint of what the spread of the questions that you are expected to encounter during the exam. As you can see, if you go down, you even have about 7 or 8 questions of basic sciences there, 3 questions on research. So it's a comprehensive test of ophthalmology and day-to-day practice in the NHS in the UK. Again, a couple of examples. Just putting this example in particular because you are expected to read recent studies and also know a bit about it, at least in terms of trying to give pen notes of how things work with recent studies. So the way I approach them is I used to make 10 bullet points of each study, and most of the times it would help me answer these questions. Books slightly different, Oxford Handbook and Kansky. More importantly for the written and the clinical part, Kansky has got excellent pictures, there's no doubting that. That always helps to put a face to the description of the picture. Moorfield's manual, I personally used it a lot during the examinations. I always felt that that is a good practical source of how practice works in the UK. So it's very pinpoint, it is quite concise, and it gives you useful knowledge. There are also books that people have written who have passed previous exams, MCQs for Part 2 FRCOPHTH. This is, again, these are books written by trainees who have passed this examination. And they're also popular and a legendary Chua website as well. There are other resources. I used Off the Questions, and they had an FRCOPHTH module separately. And quite a lot of these questions were reflected in the actual exam. The Royal College has their own clinical guidelines and the service guidance. It's worthwhile going through them because you might get questions in the theory as well as in the oral exam. And NICE guidelines, because NICE guidelines are quite popular and followed in day-to-day practice. They have their driving and vehicle licensing agency, so you're expected to know the vision requirements for driving and the GMC Good Medical Practice guidelines. Coming to the oral examination, you are eligible after you pass the written. It is held twice in the year in UK and now once in Singapore, and recently they're going to soon start it in India. Again, max of 4 attempts. Once you pass the written, you can give Part 2 oral for your 4 attempts within 7 years. Structured Viva on Monday and Tuesday, and OSCEs on Wednesday to Friday. That's the standard format of examination. In Structured Viva, we have 5 stations. Each station has its own significance. Station 1 is patient investigations or data interpretation. Devendra actually touched lightly upon in the Glasgow examination as well. They'll give you an OCT picture, for example, and ask you some questions, ask you what's the diagnosis, what do you think is the most common diagnosis, and a differential diagnosis. They'll give you a biometry and ask you to interpret it. Stations 2 and 3 are patient managements 1. So what they try to do is they try to cover all ocular emergencies, because you cannot get an ocular emergency patient to see face to face. So they try to gauge that knowledge on a Viva station. Station 4 is attitude, ethics and responsibilities. Station 5 is audit. Now Station 6 is the communication skills of OSCE, where you have an actor who will pretend that he's not happy with the way your colleague has treated him or her, and you'll have to basically talk the patient, the person out of, try to address the concerns and try to escalate if it is worth escalating. So for stations 1 to 5, there is one examination, and station 6 has 2 examiners. One is a consultant ophthalmologist and another is a lay examiner. Station 6, now post-COVID, they are getting back to getting face-to-face patient contact. So all these last 2 years, they based this examination completely on videos. Now they are trying to marry both up. So there are 5 stations. The 6th station, that's the communication skills station, it's taken care of the Viva aspect of the examination. So now we have 3 patients per station. So in anterior segment, glaucoma, posterior segment and strabismus, we have 1 patient, but they still use 2 videos. So that actually, I think it's a blessing in disguise. So you still end up seeing 3 patients. Sometimes due to lack of time, in face-to-face, you might end up seeing only 2 patients. That doesn't change the marking of the examiner as such, but it just gives you a broader variety of getting different diagnoses through. Except neuro-ophthalmology, I just wanted to highlight this point to Rashmin sir. They still didn't manage to get videos of neuro-ophthalmology patients, so they still want 3 patients of neuro-ophthalmology to be seen. You will find these videos on the college website. Again, it's a hybrid format starting from November 2022, as I just discussed. It tests all your clinical skills, as mentioned. All this is mentioned in the college curriculum on the website. How to go about? Devendra already highlighted it. With Viva, you just have to be well versed with clinical scenarios in OSCE. Practice, practice. The more you practice, especially subspecialty clinics, because as they consider this to be an exit level examination, you might get a lot of odd nystagmus cases as well, which you might not have seen. So it's useful watching a lot of videos if your center does not have access to patients specifically. Other resources such as college guidelines, the NICE guidelines, GMC documents, DVLA, strategic papers, all this is again a common lot which you can benefit by reading this for your theory as well as for your Viva and OSCE. As this is considered to be an exit level examination, I keep highlighting this during my talk, you are expected to demonstrate high level of knowledge and demeanor. You need to be at top of your game basically in terms of your knowledge and conduct, and as mentioned previously, they even mark you for facial expressions and your posture and the way you speak. Last important point, which I didn't manage to do during my anterior segment, and I got 1 mark cut off because I forgot to switch the slit lamp before I answered the question. Prepare early, score well. The best way is again to interact or consider each patient that you see as a clinic case or an exam case. To use your ophthalmic and medical care in day-to-day practice, get used to speaking that way, and that actually makes life very easy. And we had, my examination was almost more than 3 years back, but it didn't have a convocation, which post-COVID, we had it now. So I'm happy to answer any questions if you guys want to get in touch. I'm happy to share my knowledge. Thank you.